Featured in this episode are special considerations when it comes to managing the pediatric orthopedic athlete. Joining me is Dr. Curtis Vandenberg, an orthopedic surgeon who practices in the greater Los Angeles area. Dr. Vandenberg details how managing injuries in the adolescent can be significantly different than managing adults with orthopedic injuries. This includes different types of injuries that are only common and more frequent in younger populations, including osteochondritis dissecans and ACL injuries. Dr. Vandenberg is extremely passionate and knowledgeable when it comes to working with this population. I am fortunate to see his work and results firsthand. Enjoy!
The Prehab Audio Experience will teach you how to take control of your health through knowledge by optimizing performance, promoting longevity, and keeping your movement system in tune. Welcome to your host, the Prehab Guys.
I'd like to welcome Dr. Kurt Vandenberg to the show. Thanks for joining, Doc. I really appreciate you making time for this, and I know our audience will enjoy this one.
Thanks so much, Craig. It's a pleasure to be here.
Yeah, so tell us more about yourself. What do you do? Where do you practice? What's your passion that keeps you going?
Yeah, so I've been at Children's Hospital Los Angeles in practice now for about 4 years, and I'm an orthopedic surgeon. I specialize in sports medicine for kids and adults, but my practice currently is high percentage of pediatric, adolescent age group patients, and we see all things sports medicine, so anything from overuse type injuries where we're prescribing various non-operative treatments, physical therapy, so forth, all the way through surgery and doing surgery on all of the fractures. But then the mainstay of my practice is really arthroscopic surgery, including really all of the joints still at this point. Knee is probably the most common that I see in this age group. So a lot of knee pathologies, but also still shoulder, hip, ankle, and elbow.
Yeah, and for everyone that's tuning in, so I actually got to meet Dr. Vandenberg because his practice over at CHLA, they refer patients to the practice that I work out of in Glendale. And I've been really fortunate because Dr. Vandenberg and his group, they're sending over ACLs, whether it's very early on, as long as the insurance works out, which that could be an entire podcast, right? But really, it's later stage ACLs, and we're just trying to get these kids back to playing sports safely, making sure that they're prepared as possible. So it's been really awesome to get to know Dr. Vandenberg more and working with this team because I've been learning a lot. And that's why I'm excited today for him to share more information with all of us. So I'm curious, what really led you to get into sports medicine with the pediatrics and adolescents? It's always fun to hear this story.
Yeah, it's a good question. It's when I reflect back, in the last several years, this area of pediatric sports medicine, orthopedic surgery, it's kind of really come into its own as somewhat of a dedicated specialty. But I don't think I knew that when I was making these decisions back in residency. For me, it was just a matter of what are the things that I'm most interested in that I want to continue to learn more about. So I was a resident in New York City, was there for 5 years, and then I decided I wanted to do fellowships in both pediatric orthopedics as well as sports medicine because from my perspective, those are just two areas that I wanted to continue to learn more about. And so I went out to Denver for a year to do pediatric orthopedics, and then over to University of Michigan, spent a year doing a really adult sports medicine surgery for a year, and wasn't entirely sure how those two areas would overlap. I maintained sort of a broad interest in both pediatric orthopedics as a whole, general pediatric orthopedics, and even at the time was still interested in things like spine surgery, and then did my sports fellowship and started to narrow down on the things that I just enjoyed the most, the patient population I enjoyed working with the most, and then ended up, of all places, in Los Angeles, which I never thought in a million years I'd end up at, having grown up in Michigan, but I've been very fortunate to end up there in this the overlap has been interesting to see how this evolves, because I do think in pediatric and adolescent sports medicine we see some unique issues and unique injuries that really don't necessarily happen in the adult world. And I've just enjoyed working with younger athletes, working with the families. Uh, to me, it's been very rewarding, helping these athletes get back into the sports they love to do, and also just thinking about their longevity, because I'm not always necessarily thinking about getting them through the next couple months and into the next season, but what is this person going to be like in their 20s, 30s, 40s? And I think there's a huge opportunity to make a significant impact in the long term quality of life for these patients.
Yeah, and all of that really hits home with me because I would say 50% of the patients that I treat in the clinic are adolescents. And you mentioned it earlier, you do a lot of knee procedures. I mean, just on Thursday, I had eight people of my day were ACLs. And when you talk about longevity and just the research, early signs of knee OA in these individuals, or just changed quality of life for these individuals. It's so much fun to work with these individuals and try to help them because we're thinking about their longevity more likely than they are. So it's just trying to help them out. Kids, they always work so hard, and they're less likely to complain. They just want to get back to doing sports. They don't care what it takes. They'll do anything. So I really love working with kids. So speaking
Yeah, I
about
agree.
that, what
Yeah,
was that?
I would just comment on that too, Craig. I think you're exactly right. It's a group of patients that generally the issue is not motivating them. I find these younger adolescent, high school age patients are a lot of fun to work with because they really want to get better. They're motivated. They have a goal. For a lot of them, it's the goal is to get back to soccer, volleyball, basketball, whatever it may be. And so that really helps us when you have a patient that already has a goal in mind, and you can help them move toward that goal. But it's a tough injury. My heart goes out to every kid that comes in with an ACL tear. It's a sophomore, junior in high school, and that's basically means they're going to lose the better part of the next year. Maybe if they're lucky, closer to 9 months. But um, that's a big deal for any high school kid to navigate that. And so I think helping them with a kind of the psychosocial aspect of the recovery is so important. And that's where really for me, I rely on good physical therapists, because I get to see them, every couple of months, maybe in my office, and spend as much time as I can with them and navigate that process. But the therapists are there with them a few hours a week in many cases, really getting to develop a good, strong relationship with these patients. And that can just make all the difference.
Yeah, it really changes the dynamics when you have people come in that are motivated and they want to be there versus the type of patient that comes in, they're like, why am I here? The
Exactly.
complete
Yeah.
two separate cases. So,
Oh,
with
yeah.
that being said, and your practice being primarily focused on pediatrics and adolescents, can you share with our audience how the surgical options and procedures with this population can be different from those for adults?
Yeah. It's a big question. I think just to maybe narrow it down to a few specific common diagnoses or common injuries. We've already touched on the ACL a little bit, so I can share with you some of the differences in that. But I think the big factor is you're talking about a patient in many cases with open growth plates, and so that needs to be a major consideration for the management of the injury. Uh, but also, if you start getting into the surgical technical nuances, and um, and so aside from just all of the psychosocial management and helping these patients navigate their injury, which I think is different in a young athlete versus some older adult patients. But there are some specific technical considerations and just diagnoses that we frankly don't see in adults that we do in kids, and vice versa. There's a lot of things that we don't see in kids that we see in adults. For example, we're not seeing kids come in with rotator cuff tears. That's essentially an injury or a diagnosis that happens in generally older patients, other than rare exceptions. And so, one of the things, if you'd like, we can get into a little bit, is something like an osteochondritis dissecans lesion. That's essentially a pediatric adolescent age group diagnosis for the most part, and the way you manage that is going to significantly change as that person becomes older, as their growth plates are closed. So I think the way that we think about some of these injuries, the way we think about, let's say, an ACL in a young athlete, even with still open growth plates, is going to be much different. Anywhere from the timing of the surgery to the type of graft we'll use for the surgery to how we place the graft, how it's fixated, and then how we manage that patient through the postoperative rehab process.
Yeah, so I think a couple things that I would want to address first is you mentioned osteochondritis dissecans. Someone once explained this to me, and I thought it was a really good, and I would love for you to touch on it, and we could break it down for the average person. But sometimes also referred to as an OCD lesion, correct? Sometimes people will use that term.
Yeah, absolutely. It's an OCD lesion, and a little bit of a area of confusion I find occasionally is that people confuse OCD when referring to osteochondritis dissecans with the way we use OCD for an osteochondral defect. Maybe it's a little bit of semantics, but when we say OCD and let's say a 30-year-old patient with a knee injury that has a cartilage and bone injury to their knee, that can still be called an OCD lesion, but typically what you're talking about is an osteochondral defect. Whereas in a younger person, usually when we refer to OCD, we're specifically saying it's osteochondritis dissecans lesion. And that's generally a problem that happens in adolescent age group patients. The average age is typically somewhere between maybe 9 and 15 years old. And I always joke with the kids that this is not a couch potato injury. This is a injury that happens in generally pretty active patients, and it probably is in the category of overuse or repetitive trauma to the joint. And we see it all over the body. You can essentially get an OCD lesion or an osteochondritis dissecans lesion in any joint. Far and away the most common is the knee, but we see it in the elbow, particularly in the capitellum of the elbow. We see it in the ankle, in the talus, and those would probably be the three most common. But there's a lot of variability even in the knee. In the knee, the most common location by far, and it's a very interesting how there's a very specific predilection for the medial femoral condyle, and it tends to be almost on the lateral aspect of the medial femoral condyle. That's certainly far and away the most common location, but it can happen in other places. It can happen in the lateral femoral condyle. It can happen in the trochlea. It can even happen in the patella. So we see it everywhere, and each of those has a little bit different prognosis, and there's a different prognosis depending on the age of the patient as well.
And for the average person tuning in, some of these different words are the femoral condyle, the capitellum. These are just bony landmarks. So if you were to search these terms on Google Images, it would show a photo of a bone with some lines pointing to it and names for these different bony landmarks. And then, Kurt, if you can clear up any confusion here. So I think the osteochondral defect, let's just talk about a little bit of anatomy firsthand. So we have bone. So bone is a type of tissue. And then towards the ends of the bones where there are joints where two bones make contact, there's going to be cartilage around that bone. The cartilage surrounds the bone. It's like a layer to it. And an osteochondral defect, someone once told me this, and I thought it clicked very well. It's like a pothole in the road. So there's an issue with the cartilage where maybe it got cracked, something happened due to wear and tear. And that's what I always thought was like an osteochondral defect. And then correct me if I'm wrong, but then osteochondritis dissecans, that's going to be more like soft cartilage?
Yeah, osteochondritis dissecans is typically will involve both the bone and the cartilage as well. Actually, and you're exactly right in describing osteochondral defect that way, where it's both the bone and the cartilage. We do occasionally see an isolated cartilage injury where it's only that thin layer, couple millimeter layer of just the cartilage tissue on the end of the bone that's injured, and the bone behind it is completely healthy, unaffected. But more often than not, there's some degree of bony involvement. So it's not just that first 2 millimeters of cartilage tissue, but it's the bone behind it that's involved. And generally, as a treatment principle, if you don't address the bone lesion or the bony aspect of it, it's unlikely that you're going to successfully treat the overlying cartilage as well. And so when we get into this pediatric and adolescent age group and we're seeing what we think is an osteochondritis dissecans lesion, the jury's still out on exactly why this happens, but probably the current prevailing thought is there's some problem with the blood flow to that area of the bone that then causes that area of the bone to become injured. And so I mentioned that it's on the end of the thigh bone in the area called the medial femoral condyle that for whatever reason is very prone to this. And it's probably related to its contact with the shin bone in that particular area. It takes a little more force than other parts of the knee. And as a result, and again, these are kids who are super active. These are your soccer players, gymnasts, basketball players. In most cases, they tend to get this area of the end of the thigh bone that has a little bit of irritation to the blood supply. And as a result, that bone becomes weakened or injured. And one, it just starts to hurt. The patients feel it. It bothers them. They have pain in that area. And generally, at that point, we're evaluating it with X-rays and typically to really get a clear understanding of the area, we need an MRI. The X-rays will usually show it. We can see something since it is involving the bone. We can see it on the X-ray. But to truly understand the extent of it, you need an MRI to see the soft tissue and in particular see the cartilage layer. And so these are patients we're getting an MRI on. And what we're looking for is how big is it and what does that bone look like and what does the cartilage look like? We want to kind of think about separating that out into one of two categories. Is this a stable OCD lesion or is it unstable? And the simple way to think about that is the cartilage still okay, meaning it's stable, or has the bone been damaged to the extent that now the cartilage is kind of collapsing into that or cracking through, and it then becomes an unstable lesion. And that will really, in some ways, dictate the next step in how we would think about managing this problem.
And from my perspective, when I have teenagers come in or adolescents, knee pain, soccer player, okay, let's get you rehabbing. Let's do the typical things that we do. And then hopefully you're seeing progress 2 weeks, 3 weeks, definitely 6 weeks. But then there's always that case every now and then, kid comes in and he's been doing rehab for 12 weeks and nothing has changed, still a lot of pain, can't get back to playing sports at the level that they were. And this is the thing that pops up on my radar immediately. And that's when it's like, okay, well, let's refer you back to the doctor. Let's maybe get that MRI that we were holding off on to see if you would do well with this. And I've had 2 cases in my career where this is what it ended up being. So with that being said, if someone fails conservative management and say that they did it for 3 or 4 months, what are some of the different options that you begin to explore when you have a patient come back to the office, parents are there, they want answers and they want results fast? How do you go about that?
Yeah, and I can tell you, Craig, this is probably, for me, this is one of the harder issues to treat. Not because there's anything technically necessarily difficult about any of the surgeries, but each OCD lesion seems to have a little bit of a mind of its own. And so if you're an orthopedic surgeon, you tend to be pretty concrete, analytical, and you like things that are somewhat black and white that have pretty predictable outcomes. For example, ACL, there's a lot of things that can happen with an ACL, but in general, in a healthy patient with a well-executed ACL surgery and well-executed rehab, there's a very high level of predictability that patient's going to do quite well. And OCD is a little bit of this black box still for orthopedic surgeons, where it's a difficult diagnosis to treat. And I'll just go back to that delineation again of stable versus unstable. So if it's unstable and you think the cartilage is already broken through and weakened, there's probably not a significant role for non-surgical treatment right out of the gate with that patient. And so that means you're going to do some sort of surgical procedure to try to preserve or salvage the cartilage that's already there. And so you'd go in typically arthroscopically, look at that, and decide, is this cartilage salvageable? Is it still healthy enough where we can keep what's there? And that may mean putting small screws through the cartilage and bone that will hold it there and even compress it and stabilize it. And we try to, in general, use screws that are made of a absorbable or biocomposite material, so that I tell people that they'll eventually turn into bone over time. Or there's some other techniques where we can use suture anchors that are small, couple millimeter anchors that drill next to it with strong stitches that come over the top and compress it that way. So there's a variety of ways to try to fix that cartilage in and get it to heal. And then we also have to decide, is the bone behind the cartilage so damaged that we can't just leave it there? We need to go in, look at that bone, maybe remove the bad part of the bone. In some cases, even bone graft it with a small amount of bone graft, either from the patient's shin bone, or we even use cadaver allograft products to put in there. But the goal ultimately is to do everything you can to return that bone to a normal state and secure the cartilage in a way where it's going to heal, and the patient will have a smooth joint surface in the future. So that's kind of for your unstable lesion. Now, I think what I mentioned, this is a very challenging problem to deal with, is to me more in the stable OCD category. So these are the ones where they come in, we can see it on x-ray, we can see it on MRI, but the cartilage is still okay. So we're going to cross our fingers and hope that this thing heals. And if the growth plates are still open, we know that there is a chance. There's a chance it can heal. If the growth plates are closed, very unlikely that that's going to heal on its own. So boys over 16 on average, or girls over 14 on average, once they have these issues, they tend to be surgical problems out of the gate as well, and like the things I just mentioned. But the stable ones, this is where this gets tricky, because the kid may get to a point where they don't have pain anymore, at least with walking. But the minute they go back to soccer, track, running, basketball, they start to experience those symptoms again. And then they sort of re-aggravate this injury. And so oftentimes the best treatment is almost just rest, avoidance of impact activity, give it time. I like to use a general rule of thumb of probably 3 months. If I see a patient with a stable osteochondritis dissecans lesion, I want to watch that for 3 months, repeat an MRI, re-examine them, and then sort of make a decision from there. Do we think there's been some interval improvement? And do we want to try to progress them back to the activities they want to do? And during that 3 months, there may be some role for physical therapy, some role for ongoing maintenance of strengthening and motion. But we want to avoid the high impact activities, because that's what's going to get them in trouble. That's what's going to irritate this OCD lesion and potentially prevent it from healing.
And what I'm curious is, what have you seen that has gone really well versus has there been changes in medicine from, hey, we were trying this technique and we weren't getting the outcomes that we wanted? What has sort of shaped how you handled these injuries in the past couple of years?
Yeah, there are some new advances, and there seem to be a variety of new techniques that people are publishing on, but this is still a relatively narrow patient population where we don't have necessarily thousands of patients to review and say what worked, what didn't. So these are relatively small case series, but a few things that I would mention is, one, let's say this is let's just say, for example, a 13-year-old patient with open growth plates with an osteochondritis dissecans lesion, where the cartilage is okay, so it's stable. I think if you're going to attempt a conservative treatment course, setting expectations early, I found, is very important. And I'll tell people right off the bat, we're going to go 3 months. We need to be very rigid about compliance on this, avoidance of impact activities. let's plan to repeat an MRI, most likely at 3 months, and reevaluate this. I think where I've learned from this is when you start to try to make compromises right off the bat, and they say, well, 3 months seems a little long. With the big soccer tournament's coming up in 6 weeks. Do you think we can go 6 weeks this time? And you kind of have this negotiation. I think if the non-surgical treatment is going to be successful, you really need to buy into that and adhere to the non-impact recommendations, and really give that a chance, because that's the best chance we have of getting that to heal. And probably the best data on this would show anywhere from a 50 to maybe 75% healing rate in this stable OCD lesion. So not great. Most things we do, we like a better than 50 to 75% chance that it's going to work, but that's the best we have. And then let's say it's a patient who's gone 3 or sometimes 6 months of kind of avoiding these high impact activities, and we make a decision, okay, clearly non-surgical treatment has not been successful. We can keep watching this forever, but the likelihood at this phase it's going to heal seems to be getting lower and lower. Then we've made a decision for surgery. And then there is where some of the newer techniques that are being pioneered may offer a better healing potential, because even with surgery, these can be a little fickle in terms of how much we can restore blood flow to that area of the bone that's been damaged. So traditionally, the surgery that's been done is to take a small wire or tiny drill. It's about a millimeter in size, or 1.5 millimeters in size, and poke a bunch of tiny holes into the cartilage and bone. And what the hope there is that it stimulates some bleeding and some bone marrow into that damaged portion of the bone to revascularize or to allow blood flow to once again come into that. I think where we're getting a little bit better is taking it a step beyond that. One, with some of our fixation options. I mentioned these small screws that can drill into the cartilage and bone that compress the area while still not staying there forever. They're not metal screws. So we have some new implant designs that are helpful. Some of the suture anchor designs and sutures we use can offer fixation and compression over that damaged portion of cartilage. And then some of the really newer ideas out there include actually coming behind the cartilage, so just through the bone, and really drilling out or reaming out the damaged portion of the bone, and behind that, filling it in with some sort of bone graft material, and possibly even the patient's bone marrow that we take from their pelvis, from their iliac crest. So those are some new thoughts out there. I think some of these need to be more well studied, but the reality is surgeons aren't that happy with the outcomes on this. We want to get this to a 95% plus success rate, and a lot of the surgical options we have are still not quite in that area. So that's why we're seeing innovation. But I think there's some hope in the area of biologics, incorporating the patient's own cellular material, such as the bone marrow injection into this area to try to really get these to heal.
And, you brought up the idea of expectations with pediatrics. I mean, that's probably the most important thing to address day one, because it's never the kid there by themselves. It's the parent is 99% of the time there, hopefully. And it's the parents that they need those expectations even more than the kid themselves, because outside of the clinic, they're interacting. The parents, they may be financially invested in sports, that they've already paid for certain things. So it's an interesting dynamic, but I love that. I think that's the most important thing. So that's really interesting stuff. I definitely learned a lot about that. Thanks for sharing that. And I think now would be a good time to shift gears towards ACL techniques with this population.
Yeah, ACL is a huge topic as well. Just first, on the top, I agree with you. The setting expectations from the start is so critical, and there's always a temptation to kind of tell people what they want to hear. These patients come in and they're devastated. They're being told they have an injury that's going to not only keep them out of the season that they're in, but possibly even the next sport that they were going to play. And
No,
so I, I, whenever I have a patient that comes in with an ACL tear, it's my heart goes out to them because I know how devastating that injury can be. But the silver lining I like to think about is that through this experience, they're gonna learn from it. We can get them back in the vast majority of cases, and I think in many cases they come out better athletes, more fit, with a better understanding of sort of how to take care of themselves going
absolutely.
forward. They understand, especially if we can get them to someone like yourself who can really teach them things like appropriate biomechanics and how to train and how to stretch and warm up and just take care of their body. So that's the silver lining. Is once they get through the surgery, there's a lot of things they can do to stay in shape and stay fit and stay engaged. And some of the kids who handle this really well, they come out very resilient. I think there's a lot to be taken from it from a life lesson perspective. That's just trying to look at it on the bright side. But at the end of the day, this is a devastating injury. Whenever I have a conversation with the patient and family about, this is the diagnosis, we're seeing an ACL tear, this is the treatment I recommend, which is generally surgery. Going through the process, from my perspective, this is at least a 9-month recovery before I feel comfortable sending them back into full competitive sports for the most part, with some unique exceptions. But I know that they leave the office, and despite the 45-minute conversation I had with them about all facets of the surgery, the recovery, the rehab, they remembered one thing I told them, which was, this is going to be 9 months. And
Yeah.
you can literally see them doing the math in their head. Okay, it's June. So if he said 9 months, I can be ready by March. And that, that's fine. But I think there's a lot of education that goes into this. And that's why having a whole team approach is so important. Having a therapy team that's bought in, that can be a resource for the patients as well, educate them, because it's a long process.
Yeah, and immediately, even then, the 9 months, that's if you work really hard. I actually wrote a letter of recommendation for one of my patients for high school because, I mean, to go through an ACL rehab, it's so hard, it's so challenging. It's even more challenging as a teenager because you're going through life. It's a interesting time where you're learning more about yourself. Your priorities are all over the place. It's between school and social life and sports, and now you have to add in this entire facet of, now I have to rehab, and I have to take care of my knee 7 days a week, and I need to do this over the next year just to get back to playing my sport, and then I have to keep doing it. But that's one of the number one things that I mentioned in the clinic. Like, you have to find the positives, and you have to make light of the situation. And I tell kids and I tell their parents all the time that, as bad as this is going to be, we're going to make sure that this never happens to the other side. You're here for your knee, but we're going to keep your hips healthy. We're going to keep your ankles healthy. You're going to be a better athlete because of this.
Yeah, I completely agree with that. I think it's so important to stay positive, to focus on kind of the next goal ahead, whether that's the first few weeks and you're focused on managing swelling and getting range of motion back, or the early phases of strengthening. And one of the cool things that you guys have done with your group is this ACL club, because part of it is these kids feel, why me? All my friends are out playing, and I'm the one who got the ACL tear. But just a little bit of camaraderie of other people their age going through the same issues, I've found to be just really, really powerful.
Yeah, it's really changed how we're managing these athletes and what we're teaching. It's been really cool to work that class. We're running it Mondays, and we're just teaching kids, what a proper warm up should look like, how you're supposed to work on landing mechanics, jumping, working on deceleration and acceleration, doing a bunch of strength training, and then last but not least, making it fun and doing conditioning. So you brought it
Hmm.
up earlier in the talk, but even how surgeries can be different from adolescents to adults is the timing with the ACLs. So we can go through a whole little scenario here, but say that someone tore their ACL, they're in the clinic with you. Let's talk about how the timing of the surgery is going to be a little bit different for an adolescent versus an adult. What goes into consideration?
Yeah, I think the thinking on this has really shifted probably in the last 15 to 20 years. Not that I've been doing it that long, but just reading back on the literature and talking to people about how these were managed, let's say even 15, 20 years ago, is the traditional thinking then was this is a kid. This is a kid that's still growing. So let's say this is a patient with an ACL tear that has open growth plates, which generally again means girls under 14, boys under 16 on average. There's certainly a bell curve to that. But the thinking was let's get them to being done growing, and then at that point reevaluate where they're at, and if they're having problems, such as a feeling of instability in the knee, then you'd go in and do the surgery, which would be an ACL reconstruction. Generally, that has shifted significantly to thinking we want to stabilize these knees essentially right away, with rare exceptions. Most of the literature on this topic would say that if someone has an ACL tear, especially in the young athletes, these are your adolescent, teenager patients who are the most active of anybody in the population. They're the ones doing the stop and go sports, the cutting, pivoting, twisting, and that's where the ACL is functional. And if this person is out there doing these activities, it's very likely one, they'll feel unstable. They'll generally report, my knee feels like it's either giving way, it's giving out, it's clicking, it's hyper extending. People describe it in various ways, but what they're generally describing is their knee is unstable. And the dangerous part of that is it's not just that they feel unstable, but there's probably damage that's happening in the joint as a result of that. So we know that when someone has an ACL tear, there's a high rate of things like meniscus tears and even cartilage injuries, let alone someone who continues to play on an ACL deficient knee or even live with that ACL deficient knee. There's multiple studies at this point that have shown a high rate of increased meniscus and cartilage problems. So if you're running around or even walking around for that matter and living your life with an unstable knee, uh, you're set up for developing potentially irreversible cartilage and meniscal changes in your knee. So for me, unless there's some extenuating circumstance, I generally recommend surgically treating the ACL tear even in a growing athlete. And what we know is there's now safe ways to do that, where clearly if you're going to do surgery, it's got to be done in a way that's going to minimize any chance of damage to the growth plates. So that's kind of the first part of understanding that I try to communicate to patients and families is we don't necessarily want to wait. Let's say the kid's 13, 14 years old with an ACL tear. I think the wrong thing to do, in my opinion, is to wait 2 years and fix it then, because you may have really waited too long, and then their knee is really actually has degenerative changes, which can't be just quickly reversed. So that's the first part is, yes, I think we should fix it. I think we should do an ACL reconstruction in most cases. And then it from there depends on how young are they, how much growth do they have remaining. I can tell you there's actually no consensus per se on how to manage this. I can share with you what my algorithm is, and maybe I'll caveat that with say take this with a grain of salt, because I have not seen anything that really would define a true standardized protocol for how to technically manage an ACL tear in a growing patient. But the way I like to break it down is I like to think about how much growth they have left. And so I put it in sort of one of four categories, with the last category, four, meaning they're done growing. The first category is these are your really young patients. These are your fourth through sixth grade type patients that we actually do see patients this young with ACL tears. And they're often sort of pre-pubescent. And in female patients, that means pre-menarchal in many cases. And so these are young kids that have not hit their adolescent growth spurt yet. And they probably have more than 3 years of growth left, somewhere in there. And so for that patient, we say we can't take any chances drilling around the growth plates. We want to do a surgery that's going to be the safest possible for avoiding any damage to the growth plates. So for me, that's one that I would do an iliotibial band graft for. And the way that is technically done is we harvest the IT band and keep it attached to the tibia distally. And we take a portion of the iliotibial band pretty high up the thigh, often even 17 to 20 centimeters up to the thigh. So almost to the mid thigh, we take the IT band. And then that graft is taken out, but still kept attached to the shin bone distally. And then we loop it around the back of the outside or of the lateral side of the knee, pull it into the joint, through the joint, and then under the meniscus, really under the intermeniscal ligament, it's called. And then we attach it to the shin bone, attach it to the tibia. So that the nice thing about that one is that you're not drilling any sockets in the bone, which is where you can potentially cause damage to the growth plates. So no sockets are drilled, no drills are used. We just take the IT band, pull it through. You'll hear it called a variety of things. It can be called an over-the-top technique, meaning we just pull it over the top of the femur, not through sockets in the femur. And that was really popularized at Boston Children's Hospital. They were sort of the original place to publish their outcomes on this. And amazingly, it does really well. And so sometimes I almost ask, why don't we just do this on every patient? Because it's a straightforward procedure. It's safe. And frankly, it works quite well, even though you'd say it's really non-anatomic. Many ACL surgeons will talk about the most important thing is getting the tunnels in the exact position. When we drill those sockets in the shin bone, in the thigh bone, it's got to be perfect, right in the anatomic location. The over-the-top IT band technique is certainly not anatomic, but it works quite well. One of the reasons for that maybe is because as the IT band is being brought through the outside of the thigh bone, we also suture it over there. So you kind of get a 2-for-1 reconstruction where you get the ACL inside the joint, but you also recreate a ligament on the outside lateral part of the knee joint, somewhat similar to possibly the ALL or anterior lateral ligament. So it's a very nice procedure. And it's a very good option for these really young, skeletally immature patients with significant growth left. So that's any questions on that, Craig? You want me to keep going?
No, I think that's great. Talking about the ACL IT band techniques, that was definitely something that I got exposed to a couple years ago, and I've seen excellent outcomes. And for everyone that's tuning in, I've seen the surgery from Dr. Vandenberg himself. I've also seen it from another surgeon in the LA region, and these patients, they do very well. So I think it's really exciting that we have alternatives that are bone sparing for this population. But then also, so what if IT bands what if it isn't an option? What are some other things that you do with these groups? And then maybe we're moving down the line of the buckets. Let's say, what is bucket number 2 and bucket number 3? What are some options for them?
Yeah, so moving down is you're getting to a kid who's a little bit older. Let's say they've kind of maybe entered their growth spurt, and we say we think this patient has approximately 2 years of growth remaining, somewhere in that ballpark, maybe between 1 and 3 years of growth remaining. And the way we evaluate this is actually getting a bone age X-ray. And so there's different ways to do that. But I like to actually get an X-ray of the hand and wrist. And we have an atlas, and there's different tools we can use that will show us how old is this patient from the bone age standpoint. Because obviously we know how old they are. We know what their chronologic age is. But sometimes kids are a little bit of late bloomers, early bloomers. And so we want to know how much growth do they have left. So if I feel a kid is in that 1 to 3 years of growth remaining category, that's one where I say I don't know that I want to do an IT band at this point. I think we wanted to go with a little bit more of an anatomic ACL reconstruction option. And that's where I will shift then to doing a socket on the femur side where we stay below the growth plate. So we can still get it where we think is in the perfect spot on the femur. So it's technically an anatomic reconstruction, but we just orient the tunnel so that it stays the whole time below the growth plate. Because typically the way we make it would go kind of right square through the growth plate, right in the spot you wouldn't want it. So there's a way to do that. There's devices that allow us to drill those sockets in a safe location. It's a little more nuanced. We need to have X-ray in the surgery and make sure we're doing it in a safe location. But it's a reliable technique. And then on the tibial side, since the tibial space to try to do it only above the growth plate is so narrow, we'll typically go through the tibia, but try to minimize the size of the tunnel and the angle that we do it on. We want to do it relatively vertically so it prevents it from being too much of disruption to the tibial growth plate. And there's studies on that say maybe we're taking out about 5% of the surface area of the tibial growth plate, which has not been found to lead to a significant rate of growth problems in that well-selected patient age group. So we call that a all epiphyseal or growth plate avoiding ACL reconstruction. And we're usually doing that with a soft tissue autograft. And so, different conversation probably, but in general, in this adolescent teenager population, we're exclusively using autograft. I personally don't think there's any role for allograft in this age group other than some special revision scenarios or some rare extenuating circumstances. But generally, we're using patient's own tissue because we feel that the rate of re-tear is going to be lower. And for these ones where we're staying out of the growth plate, we're usually using a soft tissue graft, which leaves you with either the quadricep tendon or the hamstring option. I personally like to use the quad, but there's good outcomes and good data on both of those.
And for everyone tuning in, an allograft, also referred to as like a cadaver tendon. So if you hear cadaver, basically same thing as an allograft versus auto, think your own body. And again, I've seen a handful of quad tendons from you and some other docs, and they do really well too. When I was in PT school, I never heard of a quad tendon. So I think that, it's just having all these different options. I think that's what's really cool.
Yeah, and I don't know that anybody has the right answer to it. If you go to an orthopedic conference, this is the 1 hour debate every meeting of which is graft choice is the best. To some extent, you can find literature to support all of these, and I think they're all potentially good. Some of it is surgeon preference, what they feel comfortable with. The reason I like quad, and I actually in my training did majority hamstring, but since I've started in practice, I've somewhat shifted to quad for a few reasons. One is, in general, I find it more predictable to get the graft size and diameter that you want. Whereas with a hamstring, you harvest the hamstrings and then you realize that the size of the graft is not quite as large as you'd like it to be. And you only have so many options at that point to increase the thickness. So I like the quad for that, as well as it doesn't seem to loosen over time as much. And there may be some benefit of not taking the hamstrings in particularly female athletes who we think may be quad dominant in the first place.
And then to wrap up this exact topic, you can call it, the surgery options and procedures with adolescents and pediatrics compared to adults, is there any other overarching themes to it? Anything else that you would want to touch on? I mean, we covered a lot there. I learned a lot myself.
Yeah, we did actually already talk about the OCD lesions, and I think that's an area that's a little bit of a unique pediatric entity. And we see that not only in the knee, but we see it in the ankle, in elbow, and in general in pediatrics. I think we just want to be a lot more aggressive about long-term preservation of the joint. And so let's say with a knee surgery, with a meniscus tear, we sort of do everything we can to do a meniscus repair in many cases, unless we truly think it's in a location or the tissue quality is just very, very unlikely to heal. We're pretty aggressive about preserving native anatomy, the patient's cartilage, meniscus, whatever it may be, just thinking about the long-term health of that patient. Um, there's certainly nuances to a lot of the surgical techniques in the shoulder as well, how you manage instability, when and how in a younger patient. But I think really it comes down to, this is a group of people that are at the most active point probably they're going to be in their life. I hate to say it, but most people, they get out of high school, get out of college, you can certainly stay active, but most people are not doing as much cutting, pivoting, twisting sports, competitive sports, things like that. And so it's just a different goals that these patients have, and different level of stress they're going to put the repairs through, the surgeries through, and that needs to be taken into account surgically and technically, but also just advising them with your postoperative protocols, possibly, whether that's more time for healing or just more aggressive on strengthening before you send them back out to sports.
And I think this is a perfect segue to now talk about it. But I know over at CHLA, you guys have a sports motion analysis lab, as well as, I mean, that's the real big hot topic. And in return to sport, especially as there any lower extremity injury, ACL, you name it. So I would love to know how that's impacted your practice clinically. What have you seen that you've liked? What would you like to see more of or less of? We can basically finish up with this.
Yeah, the Motion Lab's been something I've just been fortunate that it was there when I got there at CHLA. So I've been lucky that I've been able to incorporate it into my practice, because actually at the places I trained, it was not really significantly being used in sports medicine. So what I like about it, and I'd say the primary use for it that I've really utilized it for, is for ACL rehab, and for certain kind of patellofemoral pain syndromes, or even patellar instability issues where you think maybe optimizing their mechanics and neuromuscular control may actually help the problem. So lower extremity issues like that. But for the most part, it's been in the ACL injured patients in their rehab. I like to send them to our Motion Lab somewhere between maybe 7 and 8 months post-op on average, as long as they're progressing well. And for me, it takes kind of all the emotion out of it from talking to them in clinic and determining if they're ready. This is a really quantitative, objective analysis of where they're at in terms of their recovery and strength. And so there's different protocols. The one that we've used, again, that was already essentially in place when I got there, that has been developed by people that are much more experts in the field than I am. But what I've learned from them is that so many of these things are about proximal control. If you were to ask me a few years ago what I thought was important in terms of motion analysis, I would have said quad strength and hamstring control and lower limb control. But really, we're finding a lot of these things are about higher, more proximal core, hip, pelvic control. And I was just, before we talked, I was looking at once more just the parameters that are measured. And what they look at in our Motion Lab is 6 different movement patterns. They look at heel touch, drop jump, lateral shuffle, deceleration, single leg jump, and sidestep cut. So those are the six movements. But then within those 6 movements, they then look at hip stability, pelvic stability, trunk stability, shock absorption, and hip strategy. So nothing in there said anything about the knee specifically. It's all about proximal hip, core, trunk control. And so it's all about hip abductor strengthening, core, gluteal strengthening, and these patients re-educating themselves on what are healthy mechanics, kind of avoiding that dynamic valgus collapse position, where we all know is how you can get into trouble and potentially tear your ACL, or a number of other things as well. That's probably the movement pattern that will lead to patellar instability in patients who are struggling with their kneecaps coming out, or just ongoing anterior knee pain or patellofemoral pain. So there is a big role for this. I think it's a modifiable issue. In other words, just because you have bad mechanics doesn't mean you're going to live like that the rest of your life. So step one is just seeing where they're at, educating them, seeing what ways we can target their rehab to try to modify whatever abnormal movement patterns they have. And then in some cases, actually reevaluating them and seeing how well we've done in trying to improve that. And so for me, the people in the lab make it very easy for me. They do all the work. They get the motion analysis study, and I actually get a score. They give us a score, and our scoring system is out of 50 for each limb. They measure both limbs, and we have certain cutoffs where we say we think this person's at still pretty significant risk for some kind of re-injury if we don't improve this. And then we get to certain levels where we say this athlete's ready to go. They've really done a great job in their rehab. Their mechanics are near normal. While there's never going to be a 0% risk of injury, this is someone who's kind of done everything they can do within their control to optimize their mechanics and control of their lower limbs to prevent another injury. And so I've found it very helpful. We try to get it on everybody. We can't always, just for some of the real world issues, logistics and sometimes insurance issues. But when we can get it, it's really helped me decide when these athletes are ready. And I really think that this has led to a reduction in re-injury rates. I don't know that we have enough to study that yet. But if nothing else, these athletes, once you take them through the motion lab, they kind of get it. They're starting to see what's important, that there are modifiable risk factors. And that may be the greatest value of it right there.
I don't know what it is about this day and age, but even myself, I grew up playing video games, and when you do a motion lab test and then you get the printout and it's like green, yellow, red, like good, needs improvement, or bad, then it becomes a video game and it's a challenge. Like you want to improve your score, you want to be on the green on everything, and you just get that much more attention and buy-in from the kids. But you hit it right on the nail. I mean, honestly, the inside joke when teenagers come in and they're growing and they don't have control of their proximal body parts, I tell their parents that a strong gust of wind could blow them over. And
Right.
I think a lot of that is due to their bodies changing, their bodies growing, and it's now bigger, it's longer. Their proprioception is off. So I show kids all the time, like, hey, stand in front of the mirror, look at the position of your knee, now lean over to your left, but look at your knee, look what leaning over to the left did, or look what leaning back or leaning forward did. And then everything starts to click. So that's why we focus on all those things in our ACL club. And, whenever you guys refer patients over and they've had the testing done, it definitely streamlines some of the things that we know this person definitely needs to work on. And I think it's been great. I'm with you. I don't know if there's a ton of evidence to say it's definitely reducing risk of injuries and the actual amount of injuries that are occurring, but it's the best thing that we know. It's the best thing that we have. And I think that's the multi-billion-dollar question, is how can we try to make these things not happen again? Because unfortunately, they can and still do happen sometimes. That's what's scary.
Yep. I hear you. It's a tool. It's one of many tools. I think these things are only going to continue to become more widely adopted and more accessible, and simpler and easier to get patients in and out. But I'm with you. There's certain modifiable risk factors for these injuries and certain things that are inevitably going to happen in active patients. But the best we can do is increase their chance of maximizing the modifiable risk factors for them.
Absolutely. Well, Dr. Vandenberg, again, thank you so much. I learned a lot today. I'm sure our audience can definitely take away some points. A couple last thoughts. How can people connect with you? How can people find you? And if you have any closing thoughts.
Yeah, I'm over at Children's Hospital Los Angeles, so in there, and then I spend about half my time out in the San Fernando Valley in Tarzana. But suppose I give you my email. It's cvandenberg at chla.usc.edu. And closing thoughts is keep up the great work, Craig. It's been a pleasure, and thanks for having me on.
Absolutely. And I'll be sure to include that email in the video notes. All right. Thanks again. I hope everyone enjoyed this one. Thanks for listening to this podcast with Dr. Vandenberg and I. Please don't forget to rate, review, and subscribe to our podcast. This tremendously helps get the word out about our information and our education. If you enjoyed this podcast, check out the show notes. You can find Dr. Curtis Vandenberg's email there where you can contact him. Also, we have other podcasts that we talk about ACL specifically. If you just go back and look at some of the earlier episodes, you'll be able to find them. Take care. Hope to see you again.